right now. Closed captioning is available if you need it, so please feel free to activate that. We have a Q&A option that's available. The chat, I believe, is disabled, but the Q&A is available. We have a packed agenda today, and so in the interest of allowing our fantastic panelists to get through all of their content, we may not be able to answer all questions live, but we surely encourage you to drop any questions you have in the Q&A, so that we might have an opportunity to respond in written format or to follow up with you after the event. Finally, after the conclusion of this morning's webinar, all participants will get a recording of the webinar as well as additional materials. If you're unfamiliar with Groundwork, just a quick note about Groundwork Ohio's mission. We are a committed, nonpartisan public policy research and advocacy organization. We focus on championing high-quality early learning and healthy development strategies from the prenatal period to age 5 to lay a strong foundation for Ohio's kids, families, and communities. Thank you so much for joining us. If you're new to Groundwork, we appreciate you. A quick plug also for an upcoming event next Thursday from 8 a.m. to 4 p.m. in Columbus. We have convening in person our Momentum event. This is our advocacy training event of the year. Tickets are selling fast. Seating is limited, but we would love to see you there. There's a QR code on the screen here if you're able to scan that. And one of my colleagues is going to share the link in the chat if you prefer to click the link, but we would love to see you there, and I'm hoping we'll consider joining for Momentum. Quickly, just to share kind of what this agenda is going to look like, we have Linan Gutierrez, who is the Groundwork Ohio president and CEO, who will be functioning as a moderator for 3 separate panels of experts. We'll be starting with a historical perspective, looking at where we've been on this issue in the past. We'll move forward into current progress, what's working now, what kind of work is happening around reducing infant mortality in Ohio now. And finally, we will end with a forward look, what's next, what's on the horizon. And I see here my name at the bottom of the screen, and I realize I didn't introduce myself. I am Caitlin Feldman, Policy Director with Groundwork Ohio, and I'm thrilled to be convening this conversation. Without further ado, I'm going to stop sharing my screen because we are going to hear from our first panelists, including former Senator Charleta Tavares and former Senator Shannon Jones, who will be sharing their perspective on the work that they've done on infant mortality for the last decade. And Linan, I will pass it over to you to moderate this fantastic panel. Thank you so much.
Thanks, Caitlin, and good morning, everyone. I'm Linan Gutierrez. It's nice to see you. We are pleased as we kick off this panel first to release a new report that Groundwork is releasing, and this panel will certainly complement here today, titled Infant Mortality in Ohio, a 10-year look at the impact of policy changes and opportunities for the future. So our team in conversations with many of our stakeholders have tried to provide a kind of unique collateral asset and a unique report in terms of where we've been to provide a foundation and potential for where we can move forward. So we're pleased to share that. We're going to drop it in the chat and encourage you all to engage with it and utilize it in your local communities to help educate all of our state policymakers where we've been and where we can go. So without further ado, we're going to move forward to our first panel that really focuses on where we've been. So joining us is Senator Tavares and Senator Jones, and I'm going to start with Senator Tavares. So you have really been a pioneer in health policy in Columbus and certainly across the state, and your knowledge is deep. Can you talk about why the impact of Ohio's infant mortality rate on your constituents and patients is so important to you and to the community, and why it's important for communities and the state to pay attention to infant mortality?
Thank you very much, Linan. I've been involved in this work since I was a young staffer to a state representative. And this was back in the 80s, where we created the Ohio Task Force on Black and Minority Health. And back then, we saw the startling statistics on infant mortality. And so I started my work then. Been trying to address it on a consistent long-term basis, trying to identify the best practices or promising technology strategies to reduce infant mortality. For my patients at Primary One Health, it's critical because we serve a disproportionate share of Medicaid and underinsured moms and families. And so these are the families that need our services, need our health services, but more importantly, they need services focused in on what is going to make their birth outcome positive and to ensure that their children live past the year of one. We've got a couple of programs that have been very successful in helping to reduce premature birth and low birth weights. Centering pregnancy, which was one of the models that came out after the commission undertook its work. And then the other is the Healthy Families America and the Home Visiting Program. Both of those are programs at Primary One Health with our Women's Health Division really helps to eliminate some of the fear that moms have, some of the challenges that moms have, and having that coaching along the way, not only with our team members, our clinicians and support staff, but also women who are in pregnancy term about the same as theirs.
Thanks so much for sharing. Senator Jones, you were a Republican legislator. Senator Tavares was a Democratic legislator. Can you talk about how you two came together to work together on this issue?
Sure. I mean, first I would just, in the interest of full disclosure, say it's a pretty embarrassing story for me because, and humbling story for me because I had heard Senator Tavares and Senator Miller and others talk about health inequities generally and the infant mortality rate. And it never really clicked with me. I didn't really understand. And it wasn't until we were in a health committee meeting, receiving a presentation that had nothing to do with infant mortality, by the way. It had to do with a really technical strategy for payment systems for hospitals, like really sexy stuff. But as part of that presentation that we were receiving, there was this one slide that talked about the death of Black babies versus white babies in Franklin County. And for whatever reason in that moment, it still just bothers me. It just hit me like a ton of bricks. And I remember looking over at Senator Tavares and said, wow, like I get it now, and we're going to do something different to deal with this. And so I was the chair of the committee at that time. And after that meeting and some reflection, I reached out to the senator and said, look, this is something that transcends partisanship. And let's start by going into the communities and listening to how this is impacting families, how communities are addressing it. And that really just set us, on this course to do something different. So I wish it happened sooner. Some of the work that I'm most proud of and the relationships that I value so much really stem from the partnership that we had. But I guess, as they say, better late than never. And I'm thrilled that I get to continue this journey alongside of her as we try desperately to do those things that we can to move the needle.
Thank you. Senator Tavares, you and Senator Jones did a lot to raise awareness of the challenge when you served in the legislature, and Senator Jones mentioned those listening sessions. Can you share some of the work that you did together that built trust between the two of you and paved the way for the policy changes that were made in the state as a result?
I think I'm very proud of the work that we did to kind of lead up to our model legislation, Senate Bill 332. The listening tour was very much a creative way to go around the state and build support from the communities that were trying to tackle this issue, along with those of us in Columbus with the state legislature. Communities like Cincinnati and Dayton and Youngstown and Columbus, around the state, listening to the clinicians, listening to the moms and families, listening to other support systems, other health and human services systems on what they're doing. And then to look at some legislation. We had 4 pieces of legislation. Was it 4 or 5, Shannon? That we offered as a package. But they each had their own bill number. And, you know, we really wanted to build that groundswell of support, creating Infant Mortality Awareness Month, safe sleep, and really doing an educational piece on safe sleep, because so many young people and older women were still of the mindset that it was okay to sleep with their babies and to sleep with their babies in an inappropriate way. What we've learned is that we shouldn't sleep with our babies in a bed because they can be smothered. And so learning about safe sleep. And then one of the pieces of legislation created the Infant Mortality Commission that Shannon chaired, and I was a ranking member on that committee. And that committee then enabled us to take even more of the recommendations. We developed a package. I think there were 37 or 39 recommendations initially. We pared it down a bit, but I still believe it was almost 30 recommendations in Senate Bill 332. And we really believed all of these pieces together were going to move the needle forward, move the needle backwards on the number of infant deaths in the state of Ohio. We're very proud of the legislation. It was model legislation at the time, and we still believe many of those recommendations that were included in Senate Bill 332 were recommendations that were needed at that time. Some of them haven't been implemented as much as they should be. And probably that's part of the discussion later in the conversation.
Thank you. Shannon, do you want to add a little bit more about the creation of the commission and what role it played in furthering the effort to reduce infant mortality before we move to our final question?
Yeah, I would just add the creation of the commission was really important for the two of us because it provided us a platform to bring those folks from the community to the table, where press would be there, where other members would be there, and to really lift up the work that they were doing, the challenges that they were having, and to have a chance where there could be shared learning. We also created it in a way that brought the directors of the key departments to the table to hold them accountable. And so at the time, that one decision that we made in getting that passed and impaneled gave us some tools to be able to very publicly and transparently elevate our work to make Senate Bill 332 possible. And so I think, you know, as we reflect back on the fact that while there was this great hope for progress, it really hadn't materialized. I think that we could look at the commission in a new way to be able to bring that transparency and accountability back to the conversation, so that we're holding ourselves and each other accountable to actually moving the outcomes, moving those numbers.
Excellent. So as we kind of move into some of the current work on our next panel, we would like to know from both of you, what can the state do to really move the needle ongoing? What advice do you have for policymakers, considering the progress that we're all frustrated by over the last decade?
I guess if I were to start the conversation here, I would say we need to be recommitted to the commission and the work of the commission. And as Shannon shared, to hold each other accountable, to report back. And then if there are new strategies that have been developed, new programs that communities have developed throughout the state of Ohio, we need to hear about those. We also need to bring in my opinion, folks from other states who have much better infant mortality rates than the state of Ohio. We should never be afraid to hear what others are doing that has improved their health outcomes for their populations. Let's take it and make it an Ohio version of what they're doing in state X, Y, and Z. And then my final recommendation, and I've said this from the beginning, it was one of the recommendations that was not included in the report, is that we really need to make sure all of our clinicians are trained in cultural humility, to understand the populations that they're serving, particularly vulnerable populations, whether they're immigrants and refugees, which our organization sees a lot of as our patient population, but also racial and ethnic populations. If you don't know who you're serving, you're not going to serve well. If you don't understand the cultures of the populations that you're serving, you're not going to serve your populations well. And so that recommendation wasn't included in the report. I do believe the legislature needs to look at that and raise it up, because it has been a consistent statistic from the early 80s on to now, that when you have practitioners, clinicians that come from the same walks of life, background, racial, ethnic populations, cultures, you get better health outcomes. There's more trust, there's more understanding. It doesn't mean that other clinicians of other races, ethnicities, and cultures cannot do a better job. It means they have to have the training to understand who they're serving and how they view healthcare, how they view the relationship with the clinician.
I would just, yes, amen to all of that. And I guess I would add that the state of Ohio pays for more than half of the births in the state. And so they have an outsized responsibility to ensure the safety of moms and babies. And I think that the state should be using all the tools at its disposal to bring the right players to the table to forge change. And it's unrealistic to think that the state, this big lumbering bureaucracy, can do deep community work, and the solutions have to come from the community. But what the state can do is utilize its influence as a payer, as a leader, in the healthcare delivery system, and force the right players to the table. That includes hospitals in the healthcare system. Yes, it includes their managed care plans that they contract with, but it also includes community partners. And most importantly, it includes the women with lived experience, because what we learned over the course of all this work is that if we ask Black women what they need, they will tell us exactly what they need. And that, is a huge payoff. So, from my standpoint, it's not about casting blame on anyone. It's like, this is a huge societal problem, and we all have to take responsibility for it. So to do that, we have to transparently hold ourselves accountable to data. The state has lots of it. They need to be more forthcoming with it and not be afraid of it. And then do the things that incentivize local communities, support local communities to bring the big players to the table. And alongside that, our Black moms and communities to co-create the solutions. And I think in just sort of recentering ourselves on that is where we'll start to see better implementation of the well-intentioned policies that whether it's Senate Bill 332 or some of the other legislation that's been out there, and to the various departments' credit, you know, there's been a lot of work on this. So not about blame, but we got to get serious. What we've done isn't working. So how do we take, you know, what we've learned and put that into practice?
Thank you, Senator Tavares and Senator Jones. We're going to move right along to our perfect segue to what's kind of happening in communities right now and where we're seeing success. I'm going to hand it over to Dr. Smith to share a short presentation to set us up for this conversation.
You're on mute, Meredith.
2024, and yet I have not figured it out. Thank you, Jill. Good morning, everybody. Thank you for coming. Thank you for the invitation groundwork. Thank you for listening, Director Wente. It is important that we are listening to each other as we are creating strategy and thinking about dollars spent. So thank you. Next, thank you. So I'm starting with old data. I'm going to be very brief about it. Between 2011 and 2018, we virtually saw no change in infant mortality. Cradle Cincinnati was lifted in 2013. Next slide, we'll look at Black infant mortality. This was the most stubborn numbers that we saw, and it was difficult here until we decided to name racism as our problem, until we decided that Black women needed to lead and that we needed to ask them, like Senator Jones said, what they wanted and they would tell us. We did so, and we saw change. So let's look at the specifics on that. There should be a slide in between that. Is that no? Maybe not. Okay, next slide nonetheless. This is what we do at Cradle Cincinnati, which is a collective impact internally, if you think of that. So there are multiple working parts. First, we have connections, and I know lots of folks have community health workers on the ground. Very essential that we are meeting the needs of our people immediately. So if you think of Maslow's hierarchy, we're getting them what they need. The Learning Collaborative, an essential part. The Learning Collaborative is where medical people are gathering together, mainly providers, but also anyone in the medical space, every other month to look at data. That data is disaggregated. It is coming from external partners from the county and the city. And we have folks slicing and dicing ways you cannot imagine. And I think that that really drives our work. If you don't have the data and you can't see it in a reasonable amount of time, you can't attack a problem or create a strategy that creates change. So I'm grateful to our partners who do that. Always working on policy, and here we are with our policy folks. And the last two things that were on that last slide, one, is the Queens Village work, which is the work where we're centering the people most impacted by the problem. So when we looked at Black infant mortality, it was extremely high. And so we asked Black women to lead, and that is the work you see happening there. And an outcome of that is Mama Certified, which could not happen specifically without BI3. These are works where people are saying, hey, I don't know what we need, but I need to ask and we need to figure it out. And so trust-based philanthropy is unprecedented, and BI3 is a leader in that for us. So thank you. So this is the internal collective impact. On the next slide, we have the external slide, which is really about, the man who is sitting in the wheelchair in the front is Todd Portune. He's a commissioner in Hamilton County. He was the leader of this work, talking about how policy really creates change and creates visibility. And he gathered together folks and started the work that's happening at Cradle Cincinnati. We have co-founders, James Greenberg and Elizabeth Kelly, both doctors, one neonatology and one an OB-GYN. But what you see in this picture is a combination of all of our hospitals that are birthing. Our HMOs are all represented here, CBOs, Black birth workers, community members who are impacted by the problem, and folks who said yes, just people who are like, I'm not sure that my job is necessarily something that is going to be directly impacted, but if I can be helpful to save a baby, I'm showing up. And this is when we implemented, this is actually like my 5th day of work when I said, all right, let's do this, guys, I'm ready. So yeah, moving into the next slide. I'm going to shout out the BI3 piece, which is really important to me, because I went to Jill and I said, hi, Jill, we have this infant mortality problem, and it is a Black infant mortality problem. If we don't close the gap, we will not see an overall change in our work. But I don't know what the answer is because I have to ask people first. So I just need you to give me some money, which most funders are like, get out, that's not happening. But Jill said, okay, And then we asked what they wanted, and it worked because we knew it was, theoretically, we knew it was. My background is in Black studies and women's studies at the academic level. So I knew where we were coming from and where we were going. So thank you. And so I'm glad that you're going to be on this call and we'll get to chat. Next slide. So I'm not going to read this slide, but they're available to you. But the short of it is that we went from a collective impact where we were really focused on and had stood on the shoulders of a grant that came out before us, Start Strong at Cincinnati Children's, spread that work and saw change in infant mortality here. We then went and made it place-based, spreading it into all of Hamilton County, and that was really just the CHWs. Then we landed the Black women as leaders, and we saw significant change starting in around 2018. And you'll see those numbers go down. And so folks ask, what is the strategy? What are you really doing? And that's the answer. So I'm going to talk about just some quick wins and also some places where we did not win, because let me not give you roses all the time. So next slide, please. So the ways in which we are evolving our strategy is everybody's like, we're working in silos. And the answer to that is go to the other silo and say, hey, folks, let's work together. And so partnership became very, very important in systems change. And that's why the collective impact works. Knowing who your stakeholders are, keeping them aware, motivated, and celebrated is extremely important. Expanding services and needs by collaborating, period. Who are the partners on the ground? And we are not in competition, folks. We are rowing in the same direction at the same goal. And then really focusing on naming the problem, adding the problem in 4 ways. The first way, we are doing connections and direct service. The second way, we are doing community activation with the Queens Village work with Black leadership. The third way is that we start to create systems accountability, which is absolutely important. It is not about blame, it is about support, which is also very important when you see the Mama Certified work. Next slide, please. So what's working? Data, shared data. Thank you to the state. The easier to take the data, to grab the data, the better. So that is an ask of mine. Being able to focus that in targeted areas where infant mortality is high. So if you know the data, you know where the things are happening, you can go straight to it. Listening to Black women and doing what they want, creating a solution. If it is not something you are dealing with or a body you are living in, is not sustainable. So that has been the core of our work from the beginning. And then including a variety of folks at the table. And I think I've said this several times here. Everybody's got a role to play. And so thinking about how do you talk to folks so that they hear you and so that they are motivated by this work rather than demonizing or weaponizing data or information. If you do these things, you get to celebrate with your team in Hamilton County and the folks who are rowing in the right direction. And so last year in 2023, we saw our infant mortality rate drop to 5.5, which is below the national average, below the state average. And most importantly, it was the goal that we set when Cradle Cincinnati started. We would be below the national average. And everyone said, get out of here. You are the second highest county of a high infant mortality rate in the nation. If you're thinking you're going to make those kinds of moves in that amount of time, you're out of your mind. And here we are. The belief that we can do these things, I truly believe in the work of the collective. And so I'm grateful, truly grateful to be here, but also want to acknowledge that it is a work of everyone. Normally we say, but the Black infant mortality rate is stubborn, but we don't get to say that now. We get to say that this work is working. We have the lowest infant mortality rate for Black infants as well, going into the single digits, which is another huge win. So much of it was around just keeping it clear, data, direct service, community activation, holding systems accountable. And what that looks like is pretty simple. I'm trying to be very brief so that Jill and I can talk. I think we have one more slide. So I'll just share 2 big wins because I'm sure you'll be able to look at this or record it and pause it and check it out. One of the big wins is Mama Certified. Again, it was like, hey, hospital systems, we need you to share your data. When Black women get pregnant, they feel fear and they feel shame and this is not what you want celebration. And so I went to them and they were like, girl, bye, we're not sharing data. And then I said, but we aren't gonna share, we're not gonna weaponize it. We're gonna use the data to create change. And we're gonna give you a team of people who are gonna help you do that. And we're gonna build capacity and we're gonna work together. And every one of them said yes. And that lives on a website called mamacertified.org. They are badged at how they're doing. And we meet multiple times a month and they come. And so it's the yeses in Cincinnati that's getting us there. And it's also the consistent no is not an answer. And the second one I'll say is from the state. Medicaid has our folks write anybody who's getting money from Medicaid, their applications to the Queens Village Board and no longer to the state. Therefore, the shared power of, oh, the person coming through my door may have an impact on whether or not I'm being paid, changes the way you interact. They're no longer this needy individual who, you know, you don't have to necessarily respect, which isn't always true, but still the point of shared power changes the way care is given. So 2 big wins of systems when we talk about community activation. Let's connect. I love connecting. Call me, email me, write me, join us on Instagram. Also, there are 3 websites. There's the website, the annual report, so you can look a little deeper into the data. You can look at the website of Mama Certified, looking at what that looks like for us and how we co-created that with our team of the Health Collaborative, who holds all of the data, and the Queens Village work, and anybody else who was willing to come to the table, all 4 hospital systems, and the Queens Village work specifically. So I put that in the chat, but I don't think I can reach everybody. Thank you.
Excellent. Thank you, Dr. Smith. And congratulations on all the success you are having and you will have together in the community. Jill, how are you able to use your role as a funder to get and help support all these key players to the table and be willing to be vulnerable to some of the shortcomings that there were?
Money. Money helps incentivize people to come to this table, if I'm being honest. I think that's the power of philanthropy, which we try to share with those we work with. But you know, we issued an RFP, Cincinnati Children's applied, Every Child Succeeds, which is a home visiting program, applied. We were connected to TriHealth, which we have a large OB-GYN center that serves a lot of women who have Medicaid coverage. And so I think from a funder's perspective, if you know your community and the players in it, you have the opportunity to provide a large grant, bring multiple sectors to the table. People may have not worked together in the past. You know, what we found was even our healthcare systems were very siloed. So the maternity hospitals didn't have a clear continuum of care for moms with the pediatric hospitals and maternal care. And so it was breaking down these silos and bringing everybody to the table. And I think a key one thing that really helped us a lot was having a common agenda and then all agreeing upon the fact that one of us can't solve this. We need to all come together. We have to be willing to share data and discuss what's working and what's not working. And that can be an uncomfortable place because you have, you know, 2 of the key hospitals that were delivering the most babies in the communities we were trying to help was UC and TriHealth. Well, there's a lot of competition in Cincinnati. And so to bring competing hospitals together, and not only together to work on an issue, but say, and we want you to share your data and your successes and your learnings. And so, but in doing that, you build a lot of trust and partnership, and you can continue to build the needle forward. And then finally, I will just say we funded the Learning Collaborative, which was a great way to share what we were learning beyond, you know, UC and TriHealth and the OB-GYN space, and bring in FQHCs and others who were helping moms who were dealing with infant mortality.
Excellent. Thank you for your leadership. Dr. Smith, I know you shared some of this and certainly in your presentation, but can you just underscore for us, like, what is the secret sauce?
I love that. It's also, I think, one of the questions in the chat. So I will say that it has been very consistent. The one slide, if you get to look at it, where it is like, there are Cradle Connections, which is doing direct service, your CHWs, that's what we work with. There's the Queens Village work that is about community activation. So helping you become, to feel healed and healthy and happy, or what we say, rest, relax, and repower, and hold your systems accountable. That's the piece that Queens Village is also doing. And then holding your systems accountable, and the Learning Collaborative, which is the medical folks who gather, Cradle Cincinnati Learning Collaborative. You've got to get your medical folks to talk, and they've got to talk across systems. Direct service, community activation, the Learning Collaborative, which is your medical space talking across systems, gets you systems change and outcomes. So those system change and outcomes may look different in different cities, but those pieces of the pie are absolutely non-negotiable. Things like Mama Certified are outcomes, is what I'm saying. And you have to do that in that order. And that is the secret sauce that we have watched. I will also say none of that happens without data, very real, as real time as you can get it. So we've tied our birth data to our death data. We can tie epic stuff to, so we know directly where it's happening, when it's happening, and we can move into that zip code in that month if it's sleep, and go big with the billboards, big with the bus wraps, or whatever is necessary. I think being able to have data and use that in real time with the folks who you've created a relationship with. At this point, there are thousands of people who are gathering regularly and are educated and are ready to work. So the other piece is keeping people motivated. Tell them you love them a lot. I do.
Sharing the love. Jill, what should local communities take away from your progress as they rethink their work?
Your turn.
Sorry, I was on mute. Caught myself before Meredith could tell me. So first, I will just say that Dr. Meredith Shockley-Smith and I are writing a book, and it is on Cincinnati's 10-year journey to reduce infant mortality, Hamilton County as a whole, I should say, and how what we've learned and what we've done can help other communities think about wicked problems. And that's what infant mortality is a wicked problem, because you have many factors that are contributing to this issue. You know, other wicked problems are poverty and climate change and other things. And that is not one thing one organization can tackle alone. First, I think the biggest lesson we've learned, and something that you'll find underlies our entire book, is listening to those who are closest to the problems. And that the data can tell you a lot, but it can't tell you everything. And so, for example, the data told us that Hamilton County had one of the highest infant mortality rates in the country. It told us that preterm birth, and as we got into it, especially extreme preterm birth, was the leading cause of infant death. And so you start to focus on that leading cause. It told us that there were, you know, the other two issues we were facing was sleep, safe sleep, which Senator Tavares referred to earlier, and then birth defects, which are the hardest and unfortunately probably will always be part of the problem. But really focusing in on what those were. And the data told us that a lot of moms in our community, particularly Medicaid moms, hospital data told us that they weren't entering into early prenatal care. So prenatal care in that first trimester. And that is one of the things that is very helpful in preventing extreme preterm birth or preterm birth, is that early prenatal care. And the data told us that. But the data couldn't tell us why. We had to go to moms to learn why were they not entering into early prenatal care. And some of it was the social barriers they faced. For example, mom wasn't late to her prenatal appointment because she wanted to be. She was late because she depends on a bus system and she can get there an hour before, which her job will not allow, or she gets there 15 minutes late. But it's not an indication that she doesn't care or doesn't understand that she needs early prenatal care. So there were these social barriers that need to be addressed. But the biggest thing, and I will say the root cause of Hamilton County's issue, was the distrust Black women had with our healthcare system, and for good reason. And you can read in history why they have that fear of our healthcare system. And so there was this structural racism at play, and they didn't feel comfortable, they didn't feel heard, they didn't feel safe. And so you need the data, right? The data can tell you so much, but before you act on that data, it's getting to the root problem. And if we wouldn't have listened to Black women themselves, if we would have focused all on healthcare and prenatal care, we would have completely missed the mark. So I can't emphasize that enough, learning. Secondly, the collective impact. You need multiple sectors coming together to solve a wicked problem. One sector can't do this alone. You know, we really leveraged nonprofits in the communities in which we were working who had that trust with them. And that allowed us to bring providers and have opportunities for them to relate to Black women. So one great story is we held a meal where providers could meet Black women from the Avondale community, because I would say another thing is start small. And so we started with the Avondale community. And we brought providers. They were really excited to educate mom on the importance of prenatal birth. And they sat down to break bread and they started in, and moms were like, time out. We didn't come to the table for you to educate us. We came to this table to get to know you, and that we can trust you to deliver our babies. And this is a true story, I promise. Fast forward 2 months later, our doctor, Dr. Marcotte from Tri-Health, walked in to deliver a baby at the OB-GYN center. And he walked in, and the woman, and the pregnant woman, all of a sudden he looked at her and just saw this immediate relief from her face, because she knew him and recognized him and had a meal with him. And he said, you could just see the fear until she saw me. And then she knew that I was going to make sure she got the best quality care possible. And so it's just breaking down these barriers, the relationships, right? The relationships are so critical to this work. Meredith touched on a lot of key things, but I would think when we think about a problem, we think about it holistically and as an ecosystem. So yes, programs are needed. You need to help the people who are closest to the problem to make sure that they're getting the resources and you're building trust with them. But you also need to think about the policy advocacy work. And that's where our partnership with Groundwork was critically important, because OB-GYNs were telling us women are losing coverage 60 days after they deliver. We can't address postpartum. We can't address underlying health conditions, plan for future pregnancies, right? So that policy advocacy piece, and then even the most latest is Medicaid coverage for doula services that we know really help moms. So, and it's where are the resources going? How are we building relationships with each other? How are we shifting power, which I think is a really important thing to think about, and something that BI3 tries very hard is to shift power and give our grantees power and the people that are living this power. And then finally, I don't think we can think about changing mental models. And we all have implicit bias. If you're human, you have implicit bias. How you grew up, what you've heard affects you, and you build assumptions off of that. And so just being mindful of the mental models and shifting the way things, and that's why I think it's so critically important. Tri-Health requires implicit bias training by all its team members. We did that in the OB-GYN specifically, and it was very eye-opening and very helpful, hard, but helpful. So I think it's all those things. And the last thing I just want to leave with, and I could talk forever and I won't, is that really zeroing in on what the key driver is. So if we looked at the state of Ohio and looked by county, so Hamilton County's big driver was preterm birth. And maybe that's across the counties, but really looking at each county to say, okay, what's driving this? What's the main driver? We know a lot of things are happening. What's the main driver? And then where do we see the key health disparities? And so, you know, in Hamilton County, it was a Black infant death crisis. In one of our rural counties, the health disparity might look something different. But I feel we gained traction by focusing on the 12 zip codes that had the highest infant mortality rates in Hamilton County, and started there, and started by listening to the community and building what they needed. And that in building and co-creating with the women. And that's why I will say, and I love that the data displays this, that Cradle Cincinnati was starting to help reduce infant mortality. But when we really engaged with Black women and where they had a voice and they could co-design something like Mama Certified, that's where we saw the real change. And you could see that on the graphs that Meredith showed earlier.
Thanks, Jill. Dr. Smith, any final recommendations for the state before we move on to what the future holds from Director Wente?
Money. No, serious answer is I really truly think the more we can gather together to talk about it and to create any of what I have learned and share with you so that you can help support what that looks like in the spread and scale world, and the opportunity to research does that spread well would be wonderful. Great. Already in conversation with Columbus and Cleveland, shout out to think about really doing that deeply, and Jill's support that. Thanks. Thank you for being here, all of you, and for inviting me. I really appreciate it. State's been great to us.
Thanks, Dr. Smith, and thank you, Jill. Good morning, Director Wente. How are you?
I'm good. I'm a little intimidated by this group today. So many smart women on this call. I love it.
That's right. Well, you have also, like all of these women, set a bold goal for the new agency to reduce infant mortality. Can you tell us about it, please?
Sure. So when we started the new department, we very quickly looked at some of our major metrics because, as you've heard from everyone so far today, the data matters. And transparency and accountability matters. So we had to figure out, where are we starting from? And with infant mortality, we are starting toward the bottom. Fortunately, as a state, we have hovered in that bottom quartile. We were ranked 44th with our last report. And that is unacceptable. It's unacceptable to us. It's unacceptable for our kids and families, but certainly Governor DeWine is one of the biggest champions to say, how can we fix this? And how can we start to see outcomes change? One, we looked at how to set our metric. We said, how do we get to be in the top 10? What does that look like? And very quickly they said, well, that would move you from 7.1 per thousand to 4.4 per thousand. I said, make it relatable. I'm like, I appreciate how the statistics are shared, but what does it mean in numbers? And they came back and said, Kara, we have to save 330 more babies per year. We've been pretty consistent in that 900, lower 900 range, but we need 330 more babies to be saved. That's a 37% reduction in infant mortality. Now, everyone has said you haven't seen that traction in the last 5 or 10 years, but I think Dr. Smith and Jill give us a really good example that this is possible. Is it overnight? No. But if we all start moving in the same direction, we start saying yes more than no, and we lean into those that really know the community and that are actually living it, we felt like now's the time. Let's go big, let's go bold. And I am quite okay with missing that goal by a few, if that's where we land, as long as we're tracking in the right direction. But I actually believe that in the next 2 to 2.5 years, we can get there.
So as you shared over the past decade, where we've seen and you've known that the state has invested in many initiatives to address the crisis, how are you thinking about those past initiatives as you set the course for the future? Or where do you see the opportunities for improvement as you start to act on this goal?
Well, I have to start by saying that I think everyone that's been working in this space for the past 10 years is passionate, dedicated, and all working toward doing the right thing. So I don't think it's that we look at this work and say, what are we doing wrong? It's like, what are we not doing enough of, or what are we missing? And for those of you that know me and know my career, you know that I took a short 18-month stint at the local level. And I think when being at the local level, one of my best lessons learned from coming from state to local was that I didn't use the local environment and community enough. I think what we'll see, and when looking over the last 10 years, is we've empowered them, but we've empowered them in a very disjointed way. And I can quantify that in a sense of, we've pushed out more than $70 million in the infant vitality space to more than 293 grantees. That's hard to coordinate. It's hard to collaborate. I don't know that Dr. Smith would even know everyone that we have connected with in the Hamilton County area. That shouldn't be the case. These are some simple fixes where we can say, how do we make sure that before we're coordinating, that the leaders in these communities responsible for this work know that those dollars are going out and how they're going out. So that's something you're going to see us really try to streamline in the 26-27 budget. What I also know is that I can't program my way out of this. If we could, we would have already done that. So that's why we're going to continue to engage with Dr. Smith and her counterparts in Cleveland and Columbus, Toledo, Montgomery. Pick an area where we have a high infant mortality rate. We're going to sit back as a state and say, tell us how to help. If it's bringing dollars, then we need to figure out if we can do that. If it's bringing some consistency around the way we're issuing dollars, we need to bring that. But we recognize that we can't recreate what the local level has done, nor should we, nor do we want to. We want to empower it, we want to support it, and we want to make sure that the dollars going out are going out in the way the communities want them to go out. I think that's going to be one of our biggest lessons learned over the last 10 years. but you've heard around a lot of great topics that we invest in. You know, we talk to the hospitals, we have our AIM bundles, we try to enforce best practice. How do we get more tangible in that space? How do we be more transparent and accountable? We have some of the best Medicaid coverage, as you've heard about today as well, but there are barriers. When 57% of the deaths that occurred in our year 2022 were connected to Medicaid, why didn't we have better prenatal care? Why did we lose so many babies postpartum? And when I look at the data that is most recent to say about 60% of these deaths were preventable, to me, that's a screaming cry that says this is doable to change if we work together and figure out how to listen to the right people to get to the problem and to solve the barrier. I think sometimes we're looking past that we, at the state, we stand up the program and say, we're done. But we have to figure out how do people actually access it. And that's where our focus is going to be. But again, I just reiterate, it's not going to be us figuring it out on our own. It's going to be listening to our partners who are ingrained in that community.
Thanks, Director, and for underscoring the critical work has to be championed at the local level in partnership with the state. We heard Dr. Smith and Jill talk about the importance of authentically engaging the women in the community most impacted by this work for success. How do you see the state's role in supporting that work more specifically?
So I want to start by just saying, as part of the new department, one of the pieces that we heard loud and clear early on, it's not just in the infant vitality space, the maternal health, childcare, children's services, early intervention, pick an area. What we heard loud and clear is listen to us. Don't decide for us. Doesn't matter if I'm a youth aging out of foster care or I'm a mom who's pregnant, getting ready to deliver. Listen to us who've been through it. So we have been really intentional about trying to figure out how do we keep lived experience at the table. Not recreating what's happening at the local level, leaning into what's happening at the local level, but keeping ourselves honest by having enough lived experience at the table that they can point out to us when we're not doing the right thing or when we're not thinking about the community or the person. So we really are trying to shift that culture. So I think it's twofold. It's one, making sure that we're living by the same rules we're trying to set for everyone else and having lived experience on our councils, on our commissions. We're actually looking at that right now. Senator Tavares brought up, the infant mortality task force. We're certainly trying to figure out, we have a ton of advisory groups, work groups, task force councils. How do we make sure that all of them are actually being heard? How do they roll up to make sure that there's tangible goals? And how do we ensure that there truly is lived experience with recent experience at the table? Because it does change, it does evolve. I think the other piece is just remaining flexible. I think when we talk to our partners at the local level, something we hear is, of course, always about dollars and cents, which we appreciate because we do the same thing to our federal partners. But the other piece of it is we have to be agile in approach. And you heard Jill say that. Look, go forth and do, and then show me, tell me, show me how it's working. We want to use that same premise. So I think it's a lot around listening and learning, but not recreating.
Awesome. So I'm sure that all of our participants today are wondering how we can support this work, how we can support the department and you in delivering on this bold goal. So share with us how we can help you.
So I would ask that you don't consider it the department's goal, you consider it our goal. We are only going to be successful if we are all engaged. I probably don't get invited to as many dinner parties as I used to because I bring this up. I will tell anyone that will listen that we lost more than 900 babies and that is unacceptable and how can you help me do better? I will tell anybody that will listen that I have more than 14,000 kids in children's service custody. Talk about these issues. Be real with people. Bring them and make them relatable. I would also just ask you to share success stories. Dr. Smith and Jill have done a fantastic job. It makes people feel like it's doable. When you see an individual win, a community win, share them with each other, share them with us so we can build on that because we all have rough days and these goals do seem really big. So I would just ask you to come together and share the goal, tell the story, and see who else you can get to engage and care about these topics.
Thank you, Director Wente. Is there anything else you want to share before we close out our time together?
I just want to share my appreciation for Senator Jones and Senator Tavares for really setting the foundation for this work. We have a long way to go, but we wouldn't be here if they hadn't started this 10 years ago. Dr. Smith and Jill, you guys have been phenomenal partners at the local level, and all of our partners have, no matter what area. So we look forward to continuing to engage, but also groundwork. This really is going to take all of our hands and all of our oars rowing in the same direction to move the policy. So truly, we couldn't ask for better partners, and we feel like our goals are doable because you all are willing to engage with us. So thank you very much.
Thank you, Director Wente. We really appreciate how generous you were in listening today and sharing with your time. And for all the panelists, Senator Tavares, Senator Jones, Dr. Smith, and Jill, thank you. I know it was a tight agenda today. I don't see any remaining unanswered questions in the chat, but we've provided you with a lot of information. We'll do a follow-up email so you have the webinar recording, the reports that were shared, and we'll continue to keep engaged. Please, as Director Wente has all called us to do, at least one of these things you have a few days left in September. It's Infant Mortality Awareness Month. So please elevate this conversation and continue to share and problem solve with us. Thank you and have a wonderful day.
Thank you. I love all of you. Keep working hard.
Thank you.